Good evening, everybody. A warm welcome to the Masterclass at IBDENC. This month is special. This month is special because this is the month of the International Women's Day. And on this occasion, we have got together a program on unaddressed issues, women's issues in IBD. For today, we actually have a stalwart of speakers, global experts. We begin with Dr. Bharti Kochar, gastroenterologist, IBD expert, well known for all her publications on inflammatory bowel disease from the Mass General Hospitals, Boston, USA. We have Dr. Irit Avni Beron. She's a senior IBD specialist from the Rabin Medical Center, Petah Tikva, Israel. And we have Professor Dr. Ida Helmi, close friend of mine. Ida is a professor and senior consultant in gastroenterology, well known across Asia, South Asia, Asia Pacific. She is the head of department at the University of Malaya, Kuala Lumpur, Malaysia. Warm welcome to all of you. And I think without wasting even a second, let's just get going with the first topic for the evening. And the topic is menopause and beyond. What is different in elderly women with IBD? Over to you, Bharti.
Thank you very much. Just give me 1 minute as I share screen. Hopefully you can continue to see my screen. It's such an honor to be here. Thank you once again. I'm very excited to speak to you about what is different in the older woman with IBD. So I want to start off by acknowledging what I said earlier. This is amazing to be part of an all-female panel, very rare in the field of IBD and in GI, and in celebration of this International Women's Month. And so I'm, once again, very honored to be here. Over the next 20 minutes, I'll quickly review the epidemiology of IBD in older adults, give you a very macro level overview of the aging immune system. We'll talk about the little bit that's known about hormones, menopause, and IBD, and I'll end by discussing some general management considerations in the older woman with IBD. So this graph is from a Canadian study extrapolating the rise in IBD prevalence in adults 60 years and older in the coming decade. And as you can see, the number of older adults with IBD is exponentially rising. This is both due to an increasing incidence, but also due to improved treatments and increased life expectancy. And so in the US in 2015, there was an estimate that 26% of Americans living with IBD were 65 years and older. So this is a very big deviation from what we normally think about IBD being a disease of younger people with a traditional age of diagnosis between 20 and 40 and so. This figure is from a recent global epidemiologic update on IBD, which shows that the peaks of prevalence of IBD worldwide are in the 60s here. And what you also see that women in the peach shade actually comprise a greater proportion of patients at older ages, which also parallels known life expectancy patterns. And so as IBD incidence rises and life expectancy rises, even in nations with emerging IBD incidence, you'll soon be seeing a number of older adults and specifically older women with IBD. And so I'm very appreciative of Dr. Banerjee's attempts to really draw attention to women's issues beyond reducing women to pregnancy and discussing the whole lifespan. This is very important. This immune system changes with age, and the number of, as you get older, the number of lymphoid-based stem cells, hematopoietic stem cells decline, the number of myeloid-based stem cells predominate. And this is traditionally why IBD was thought to burn out by older ages, and the concern for robust inflammation was lower. And so for a long time, we didn't pay much attention to, what to do with IBD in the older adult. But we're learning more and more that as the B cells and the T cells, they decline in number, they're also functioning less well. And this can actually create a pretty inflammatory environment. And these changes start occurring by the 6th decade of life. So that's actually in the 50s, still quite young, as people go. And also in the 50s is when women often face menopause. And so this is a nice graph showing that with age, the amount of female sex hormones, estrogen and progesterone, decrease over time. But around menopause, relatively, there's a lot more estrogen than progesterone. And this decrease in estrogen is very pertinent to us because estrogen receptors are heavily present in the GI tract. We know that estrogen receptors regulate gene expression. In mechanistic studies done in pregnancy, progesterone was shown to decrease gut permeability. And in IBD patient-derived inflammatory organoid models, they demonstrate that estrogen and progesterone exhibit a number of anti-inflammatory properties. We also know that menopause results in differential expression of estrogen and progesterone receptors. In an internet-based survey of 456 postmenopausal women with IBD, 65% of women had no change in symptoms with menopause. 8% reported improvement in symptoms during and after menopause, and 27% reported worsening. Women with worsening symptoms around menopause were older on average at age of IBD diagnosis. So in general, these women on average were diagnosed around 44 years, compared with 32 years at age of diagnosis for women who had no worsening symptoms with menopause. In a study of 196 women with IBD, they found that age at menopause was comparable to healthy controls. But they also found that a longer disease duration was correlated with later onset of menopause. Women who were diagnosed with IBD in their 40s had menopause about 2 years earlier, which is quite comparable, which is quite concerning because early menopause is known to be associated with an increased risk for osteoporosis and cardiovascular mortality. There's only one other study of postmenopausal women with IBD. And in that study, they looked retrospectively at 65 women and found that 35% had active symptoms in the premenopausal period, and 38% flared within 2 years after menopause. The women's issues are generally quite understudied. And so these are really the only 2 dedicated studies of menopause on IBD. And in the second, more recent study conducted by Dr. Kane, who literally wrote the textbook chapter on menopause and IBD, they also found that the use of hormone replacement therapy was associated with a decreased likelihood of flaring in the first 2 years after menopause, and there was actually a dose-response relationship. HRT, our hormone replacement therapy, was also associated with an increased risk of developing ulcerative colitis, but not Crohn's disease. And this risk correlated with the duration of hormone use, and it decreased after discontinuing the hormones, which suggested that the female sex hormones actually do exert some sort of an effect on IBD itself. IBD is still often managed with corticosteroids, and we know that steroids are associated with an increased risk for menstrual cycle irregularities. And in the one study dedicated to assessing the role of steroids on women with IBD with regards to their menstrual cycle, there was an increased risk of oligomenorrhea and polymenorrhea, especially with flares of IBD, and the irregularities decreased with increased disease duration. To test the hypothesis that female sex hormones exert an effect on GI symptoms, in this particular study, they focused on the GI symptoms of diarrhea and constipation. This is a concept figure from a well-designed prospective study of women in the Seattle Midlife Healthy Women's Study. And very interestingly, what they found was that reproductive hormone levels were not correlated with GI symptoms, but rather stress-related perceptions and cortisol were correlated with GI symptoms. Changing gears, we can't talk about the older woman with IBD without discussing bone mineral density. Older women are more prone to decreased bone mineral density because estrogen exerts an inhibitory effect on bone resorption. And when there's decreased levels of estrogen, there's increased bone resorption. This Swedish study demonstrates that women who have menopause early, defined in this study as 47 years, had an 83% greater risk for osteoporosis and 68% greater risk for fracture by age 77 compared with women who had menopause later. Remember, there is some data suggesting that women with IBD may experience menopause earlier. And this figure is from nearly 100,000 women referred to a menopause outpatient clinic, and it demonstrates how prevalent low bone mineral density is among women, especially as they age. You can see in this Austrian study that 30% of women had menopause had osteoporosis by age 70, and an additional 40% had osteopenia. So why do we care about bone mineral density in a talk about IBD? Because the gut is involved in bone mineralization, and inflammation influences bone mineral density through a number of pathways. These figures are from a Swedish study comparing those with IBD who had a hip fracture to those without IBD who had a hip fracture. And what you see here on the right in the yellow is that women with IBD who had a hip fracture were more likely to die. So the consequences of being an older woman with IBD can be quite significant. So we'll very quickly go to some constructs to consider in managing the older woman with IBD. And here I refer to women in their 50s, 60s, and 70s, not quite very old. But we know that caring for older adults requires a consideration for a variety of factors that are different from younger adults. Older adults have a differential risk for infection, markedly more polypharmacy and comorbidities, and it's not just the increasing prevalence of cancers, but a higher baseline risk for cancers. And perhaps most obviously, older adults don't have the same life expectancy as younger people. I think this complexity is best encapsulated by the construct of frailty, a measure of biologic reserve that signifies the body's ability to adapt to stressors. IBD and frailty have many overlapping features, such as fatigue, weight loss, an inflammatory environment, microbial changes, muscle loss. And in this Dutch study, they prospectively measured multiple geriatric domains that approximated frailty in 400 IBD patients 65 years and older. Being female was the second strongest risk factor for having deficits in these geriatric domains, and this is parallel to non-IBD cohorts as well. Sarcopenia is an age-associated loss of skeletal muscle function and mass, and IBD is a risk factor for sarcopenia. There's a growing body of literature describing a strong association between IBD and sarcopenia, and this figure summarizes potential causal pathways on how IBD increases the risk for sarcopenia. Since women start out with less muscle mass than men even at younger ages, sarcopenia becomes an important construct to consider as women age. The literature is sparse, but if other chronic diseases are an estimate, older women are more likely to have worse outcomes even with IBD. And there's many reasons for this, and this is one proposed mechanism. IBD increases the risk for sarcopenia and frailty. Being older increases the risk for decreased female sex hormones and increases the risk for osteoporosis and sarcopenia. And they're all very interconnected and culminate in adverse outcomes. So it used to be thought that IBD in older adults was generally milder, but because, what we did in this multi-centered retrospective study was show that if we account for disease duration, there's no significant difference in Crohn's disease behavior in adults diagnosed with IBD over age 60 in the darker blue and younger adults in the lighter blue. And the same was seen for ulcerative colitis patients. So if older adults do not have markedly different disease behavior, can we treat them as we treat younger adults? This becomes more complicated because, as we know, older adults with IBD in the pink have a higher risk for cancers than younger adults in the blue. And thiopurine medications used to be the mainstay of IBD treatment for many decades previously. This unique meta-analysis shows very nicely that as the decade of life increases, the number needed to harm with regards to lymphoma decreases. But this is okay because we have more modern and effective biologic agents, right? But there's widespread hesitation to using biologics in older adults. A pooled analysis of the few older adults included in 4 clinical trials of anti-TNF medications in ulcerative colitis show that older adults in the blue bars were more likely to have serious adverse events and hospitalizations, but there's no significant risk difference compared with placebo in the lighter blue bars. So while in fact older adults treated with placebo had numerically higher risks for adverse events, this was probably not attributable to anti-TNF medication on its own. And the modern and selective biologics are more likely to have an even more favorable safety profile. Yet older adults are less likely to receive steroid-sparing therapy for the treatment of Crohn's disease. And the same is seen for older adults with ulcerative colitis. And older adults are more often treated with steroids with markedly worse outcomes, including venous thromboembolism or blood clots, and fractures. And I previously showed you how detrimental fractures are. But perhaps the hesitation to use modern therapeutics for older adults is due to the lack of representation of older adults in clinical trials of IBD medications, especially of the modern biologic agents. And women tend to be underrepresented in medications as well. So there's a lot of work to be done. Since you'll be seeing many older women with IBD, it's important to understand the recommendations for screening for osteoporosis. All women 65 years and older, or women of menopausal age, so in their 40s and 50s, with a risk factor. It should be noted that IBD in itself is a risk factor, but also steroid use, especially more than 3 months continuously, are risk factors that should prompt screening for osteoporosis. So in conclusion, I will only ask that you remember the following few things from my talk today. Managing older adults and older women with IBD especially includes significantly weighing risks and benefits, coordinating care with other specialists like primary care providers, gynecologists, oncologists, endocrinologists. It's very important to contextualize the risk associated with effectively treating IBD. And so there's a Mark Lack's book titled Treat Me, Not My Age, which I think is very pertinent. It's also very important to recognize that we do not have much data behind IBD management for women in general outside the context of pregnancy and the postpartum period, but also especially older women and women in other spectrums of the lifespan. So this is always a call to action. And if there's really only one thing you will remember, please do not use steroids for maintenance therapy, especially for women and older people, but in general. So thank you very much once again for your time, and I will stop now.
Thank you, Bharti, for this excellent talk. And you've actually covered the different aspects of why elderly IBD is so important and the increasing numbers, particularly as time progresses in this part of the world also. So we'll have the question answer session at the end of the talks. So we'll go straight forward to the next talk, contraception and preconception counseling. two different aspects, finding the right balance. And over to you, Dr. Irit.
Thank you. So let me share my slides. So I'd like to thank you again for the invitation to participate in this webinar. It's a great honor. So the peak age of IBD diagnosis overlaps with the age of sexual maturity, establishment of intimate relationships, and family planning. And we as IBD physicians have the privilege and the obligation to guide our patients as they go through their journey. And as you can see in this slide, there are many aspects to consider in the preconception clinic. Regarding contraception in IBD patients, first we should acknowledge that women with IBD expect to receive counseling from us gastroenterologists in preference to primary care physicians. When we talk about contraception methods, we can divide them into two groups: non-hormonal methods, with the copper intrauterine device being most prevalent, and hormonal methods. And then we can talk about progestin only and combination of estrogen and progestin. Some of the concern regarding the use of oral contraception in IBD patients comes from data that shows that exposure to oral contraceptive pills may be associated with increased risk for development of IBD. And here I'm showing you a meta-analysis from 2017 of 20 case control and cohort studies that associated exposure to oral contraceptive pills with the risk of development of IBD with an odds ratio of 1.3. An interesting recently published nested case control study of almost 5,000 IBD cases demonstrated that exposure to combined oral contraceptive pills was indeed associated with the development of both Crohn's and UC, but use of progesterone-only pills was not associated with Crohn's and was only modestly associated with UC. And the parenteral progestin-only contraception was not associated with IBD. And this interesting study supports the hypothesis that estrogen component of contraception may drive IBD pathogenesis. But maybe more relevant for us as physicians and for our patients is the concern regarding venous thromboembolism. Because as you know, IBD and mostly active IBD and hormonal contraception are both associated with increased risk for venous thromboembolism. And when considering the best option for our patients, we can say that copper intrauterine devices can be used with no restrictions, as well as all progestin-only methods that are considered low risk. And there is some uncertainty regarding the use of combined oral contraceptions, but we can say that in women with stable, low-risk IBD, they also can be used. And in women with higher risk for venous thromboembolism, such as patients with active disease, smokers, patients after surgery, we can consider other options. And as you can see, we have other options. And to summarize this issue, we can look at the recently, soon to be published actually, ECHO guidelines on this matter, and we can say that the efficacy of oral contraceptives does not seem to be reduced in women with IBD, so the risk of absorption is not that of a concern. Oral contraceptives do not seem to be associated with increased probability of an IBD flare. And oral contraceptives are generally of low risk in women with IBD, and nevertheless, careful assessment of the thrombotic risk is recommended before prescribing. Another pertinent question for our patients is the subject of fertility. And before discussing fertility, we should be aware that IBD patients decide not to become pregnant 3 times more than the general population. And the number one reason for that is lack of knowledge and fear of infertility, heritability, and teratogenicity. And it's encouraging to note that proper counseling can reduce these rates of voluntary childlessness. Patients with IBD in remission with no previous IBD-related surgery have fertility rates that are equal to the general population. In active Crohn's disease, there is a slightly higher risk of infertility that is related to a combination of reasons, including perianal disease, dyspareunia, fallopian tube occlusion, and ovarian dysfunction. And as for the subject of IBD-related surgery, in Crohn's disease, we can't make a firm conclusion because the quality of data is not so good. And in UC, it's definitely shown that pouch surgery is related with a higher risk of infertility, so 3 times the rate, due to pelvic adhesions. And the use of laparoscopic surgery can reduce this risk markedly. And if we refer our patients to in vitro fertilization, IVF, we can tell them that the rate of success is comparable to that of the general population. IBD course during pregnancy depends on disease activity at conception, and conception at time of active disease is related to a twofold risk for active disease during pregnancy, as is shown in this meta-analysis, and this goes for both UC and CD. We have data that shows that ulcerative colitis patients tend to relapse more during pregnancy. And in this prospective echo-epicom study of 200 pregnant women that conceived while in remission, the course of IBD during pregnancy and postpartum was studied, and it was shown that pregnant patients with UC are more likely to relapse during pregnancy and the postpartum period as compared to non-pregnant UC patients at the same period. And this higher risk for exacerbation during pregnancy was not demonstrated in Crohn's disease. IBD is associated with more pregnancy-related complications as compared to non-IBD reference population. And this risk is significantly elevated when IBD is active. As we can see in this large French study that was based on the French National Health Data System with data for almost a decade and more than 35,000 IBD pregnancies, we can see that IBD, but mostly active IBD during conception and during pregnancy, was associated with adverse significant outcomes such as stillbirth, preterm birth, low birth weight, and a higher risk for hospitalization. So maybe the most important statement for my talk is that conception at time of remission can help us reduce these risks for adverse pregnancy outcomes. But in order to achieve this goal, we need to have an open discussion with our patients regarding family planning, and we need to know our patients' plans. And it is recommended that our patients would have at least 3 months of steroid-free remission prior to conception, and we should confirm remission with endoscopy or other objective markers before conception. Preconception care improves outcomes. In the well-known study from the Rotterdam Clinic, preconception counseling was compared to no counseling, and it was demonstrated that preconception care was associated with improved adherence to medication, adequate folic acid intake, smoking cessation, and reduced disease relapse during pregnancy, and reduced risk for low birth weight, so very important outcomes. Our patients are very concerned regarding medication risks during pregnancy, and therefore it's important that we cover these issues during our preconception counseling so that we can diminish our patients' concerns, and it's very helpful to have a medication plan for pregnancy. Apart from methotrexate and tofacitinib, IBD medications are regarded as low risk and can be continued during conception and pregnancy. And the concept that should lead us is that the drug that got us to remission before pregnancy is needed to maintain remission during pregnancy. If we look at conventional therapy, so 5-ASA, mesalamine, corticosteroids, and thiopurines, there is no increased risk for major congenital anomalies or adverse pregnancy outcomes as compared to the general population. And therefore, thiopurine monotherapy and mesalamine therapy should be maintained during conception and pregnancy. As for corticosteroids, the risk for orofacial clefts in the first trimester is not supported by recent literature. As you can see in the Danish nationwide cohort study of more than 50,000 pregnancies with first trimester exposure. Therefore, corticosteroids should be used when needed to overcome a flare during pregnancy, even in the first trimester. We should remember that use of corticosteroids during pregnancy is associated with an elevated risk for gestational diabetes, and this should be recognized and treated. Much of the concern regarding the use of biologics during pregnancy comes from the fact that biologic agents are immunoglobulins, and as such, they are actively transported across the placenta during pregnancy. This active transport of immunoglobulins is designed or meant to enable the infant a humoral immunity for the first few months of life. This active transport starts at the second trimester, so at week 13, but is most prominent in the third trimester. So that at delivery, cord blood immunoglobulin levels are higher than in the maternal levels, and this includes also the biologic agents. In the past decade, we've had an ongoing discussion regarding the use of biologics during the third trimester. And we can consider if we stop the risk of flare during pregnancy and postpartum and the risk of loss of response or immunogenicity when we reinstitute the drug. On the other hand, if we continue the drug, we can consider the short and long-term consequences for the infant's immune system development that are not fully recognized. We should consider the risk for infections during first year of life and the need to avoid live vaccines at the first year of life. In recent years, we've learned that the third trimester and cord blood levels of biologics are different between the various agents. And if we look at maternal pharmacokinetics of anti-TNF during pregnancy, we can see that the adalimumab levels remain constant during pregnancy, whereas infliximab levels are elevated in the second and third trimester. And if we look at the cord to maternal ratio, it is higher for infliximab than for adalimumab. And the average time to clear the drug from the infant's blood is also longer for infliximab as compared to adalimumab, so 7 months as compared to 4. And in a study from the Rotterdam clinic, they have shown that if we accept a level of 3 micrograms per ml in the cord blood, we should stop infliximab dosing at week 22, while we can continue adalimumab administration for up to week 33. So if we do not want to stop the biologic too soon during pregnancy, a balanced approach would be to adjust the dose of the last administration so that the last dose of infliximab would be given at week 30 to 32, and adalimumab may be maintained for up to week 34 to 36 for the reasons that I've shown you. And we can also consider taking blood levels for drug levels at the second trimester. If we look at the guidelines, what do they tell us about third trimester administration? And we can see at the left of the slide, the new recommendations from the European guidelines, and at the right, the North American recommendations. They all agree that when disease is active, we should continue therapy with no stopping. And in general, the American recommendations support continuation of biologics in almost all patients, while the European recommendations are somewhat more conservative. In the meta-analysis of almost 7,000 patients published in CGH, we can see that pregnancy outcomes in patients treated with biologics were comparable to the general population, including a third trimester anti-TNF administration. One of the main concerns regarding intrauterine exposure is the risk of infant infection. And in the data that comes from the large French database, we can see that in utero exposure to thiopurines and anti-TNF monotherapy was not increase the risk of serious infections during the 5 first years of life, but exposure to combination therapy did elevate the risk for infection, and therefore it is recommended that in patients with stable disease on combination therapy, we should consider stopping the thiopurine and continuing only the anti-TNF, and we can also look at the drug levels to adjust. In the past decade, we've had additional options other than anti-TNF, and here we can see data regarding vedolizumab, and the important study of Meta Julesgaard shows us in 40 pairs of mothers and babies exposed to vedolizumab during pregnancy, we can see that 70% of the mothers continued vedolizumab for up to week 40. It was shown that vedolizumab had favorable pregnancy and birth outcomes. Vedolizumab had lower placental transfer as compared to anti-TNF, so infant to maternal ratio is 0.5, and there's considerably rapid vedolizumab clearance from infants' blood, so 90% of infants did not have vedolizumab in their blood at 3 months. Regarding ustekinumab, we can learn from a retrospective cohort study of the JETED that compared women that were exposed to ustekinumab, vedolizumab, and anti-TNF during pregnancy. And also for ustekinumab, there were satisfactory maternal and neonatal outcomes. Ustekinumab, as compared to adalimumab, has stable drug levels across all 3 trimesters. The infant to maternal blood ratio is also comparable to adalimumab, 1.8. And the time to clearance of ustekinumab from infant's blood is on average 9 weeks. And just to finalize with talking about the mode of delivery, there's an increased risk for cesarean deliveries in women with IBD. But most IBD patients can deliver vaginally. And as we don't have evidence that vaginal delivery promotes perianal disease, but active perianal disease may be aggravated with vaginal delivery. And therefore, the mode of delivery should be guided by obstetric considerations in most cases. And in patients with active perianal disease or prior rectovaginal fistula or after pouch surgery, cesarean delivery is recommended after a multidisciplinary discussion. So to summarize, active IBD is the most significant risk factor for pregnancy complications. Planning is key. So conception at time of quiescent disease will reduce the risk of adverse pregnancy outcomes. Most IBD medications are of low risk and should be continued during pregnancy, including the 3rd trimester. And multidisciplinary follow-up during preconception and pregnancy is recommended. Thank you.
Thank you, Dr. Iris, for your wonderful talk. As I mentioned, we will be taking the questions at the end of the session, but I must tell you that you've made it very crisp and clear, and your talk has been very reassuring. that you should continue medications, plan pregnancy when everything is quiet. And I think that has been reiterated very well. Thank you so much. And the third talk of the day, and very important, over to you, Ida, for the nitty-gritty of postpartum care, which we see and hear every time in our outpatients, breastfeeding, vaccination, what to do in IBD.
Thank you so much for the kind invitation, Rupa. It's always, I can never say no to you because, usually I'm in India physically, but I guess if I can't, then I guess seeing you virtually will have to do. So my topic is on the nitty-gritty of postpartum care. This is just some views. And I think we all know, as my two eloquent speakers mentioned earlier, that most IBD patients are in the childbearing age. So pregnancy, postpartum period, pre-pregnancy and contraception are all very, very relevant issues to us. And that was highlighted before. I have a 39-year-old Syrian woman who was married to a Malaysian. She was diagnosed with ulcerative colitis, and she was actually a little bit underdosed for her thiopurine. She was quite heavy, but she was in remission for some time. But she was pregnant in January, and what happened was in 2020, and she had a spontaneous abortion at 13 weeks, thought to be due to cervical incompetence. It wasn't so clear, and because that was during COVID time, she disappeared from me. She defaulted follow-up, and then again. She came back when she was 16 weeks pregnant. That was in November of 2020. So I think, again, did I have a proper pre-counseling session with her? I have to confess I did not. So it just goes to show you sometimes, we all, have to be very systematic and aware of this. It didn't help, I have to say, that she really doesn't speak English very well, and she really doesn't speak Malay very well as well, and her husband also didn't speak Arabic very well, so it was all a very difficult situation. So excuse at least, but you can see here very clearly flare, yeah, and when she was 16 weeks pregnant. So I started her on steroids. But the question, of course, is what would you do in this situation? You continue her azathioprine to what is deemed to be a lower risk medication. We know that's not true, or would you stop all medications and monitor? And I think Irid already explained it very, very clearly that we should continue whatever medications that kept the patient well in the first place. But the problem was, well, she had a spontaneous abortion before, and she developed oligohydramnios, and the obstetrician who was treating her in another private hospital told her to stop the azathioprine. And I think this is a real scenario. She refused to start because of concern about her baby, and then after that she defaulted again. She had delivered a baby by SVD in April 2021, but all this time, all without my knowledge, and then she presented again with a flare. So again, she pitched up when she had a flare. I advised her to for steroids, of course, because she had a flare, and to restart her azathioprine. But again, she refused to take the azathioprine because she was advised not to take azathioprine, and she was keen to breastfeed. And I think this just tells you the very, very real scenario of what we are dealing with on a day-to-day basis. Having a baby is a very emotional time, and I'm a mother too, so I know what it's like. There's so many things going through your head at the best of times, when you don't have a chronic disease like inflammatory bowel disease, but you can imagine how difficult it is when you do. So my topic is really more to focus on what happens in the postpartum period. So let's talk about vaccination and infant outcomes. I thought I'd start with just a quick question. which is following is it true for babies who receive anti-TNFs during pregnancy? So Erin mentioned very, very clearly about the transcendental transfer of anti-TNFs. Most of them usually start at week 20 in the third trimester. We do know that it is found in high levels in newborn babies, and we do know again that overall, despite there was some earlier data with anti-TNFs in the past, and that's why the ECHO guidelines, which I'll show in the next slide, suggested that there might be a slight increase of adverse outcomes. But generally, I think it has now been established, very reassuring data, that they are not a significant risk of infection or malignancy. And again, the data on other biologics are limited, but are thought to be safe. So, again, very similar reassuring data for thiopurines as well. Again, as mentioned by my previous speaker, there is a suggestion that there is a small increased risk of infection in mothers on combination therapy. So this was the old version of the ECHO guidelines, which did suggest that for sure you can actually continue things like thiopurines, but was a little more hesitant about anti-TNF agents, although now I think, as was presented, we have reassuring data with regards to this, but there might be a slight increased risk with combination therapy in terms of infant infections. So what about in terms of vaccination? Well, most of the vaccines that are supposed to be given at birth are safe. So again, this is actually pretty assuring data. But this was actually reported back in 2010 about a case of fatal disseminated infection. And I think if anyone had come across that case report, and I think most of us where BCG is given at birth had come across it, that is going to be the biggest fear. It certainly is my biggest fear, because sometimes my IBD patients actually have babies elsewhere. They have it in a district hospital. And although, you write letters and you try to correspond, with or communicate with the obstetrician, you're not quite sure what's going to happen. So there has also been there was one case of varicella zoster infection, adalimumab, on a mother with adalimumab, few case reports here and there. So because of this, and because we do know that the anti-TNF levels are high in newborn babies, the general recommendation is that all live vaccines should be avoided until 6 months after birth, including the rotavirus. But I'd be very interested to hear, what Bharati and Irit thinks about this in terms of rotavirus, because I also thought there was some data that suggested that was not unsafe as well. A Korean study by Park et al. Showed that if you gave the BCG at 6 months, that was perfectly safe with no major outcome. Again, this was an echo statement from before, which said that you probably should avoid live vaccines, but everything else can be carried out as normal for the infant. This is an interesting study which was just published a few years ago, and it's a large group that actually looked at a French nationwide study where, although the BCG vaccine was given a bit later, not at birth, believe it or not, 73% did not actually follow the guidelines of giving it after 6 months of age. 73% actually received it before 6 months of age. And interestingly, in that study, there was no BCG-related adverse events. I personally don't think that I would have the courage to give the BCG vaccine for the baby before 6 months of age, but at least, I guess, in an accidental, administration of BCG, that's reassuring data as well. So that's the answer to that question. What about breastfeeding? So again, just like in pregnancy, most drugs are safe to be used in breastfeeding. And again, unfortunately, because of the perception and so on, mothers with IBD generally have a lower rate of breastfeeding. There's some data to support this, especially particularly from piano registries and so on. I think we all know about the piano registry. So I think it's important to counsel the mothers, because we do know that breastfeeding has a protective effect. So, you know, it makes sense if your child is genetically slightly more at risk of having IBD anyway, that they should be breastfed. Most medications are safe, but there's minimal data on tofacitinib, which is being used more and more for ulcerative colitis. So the current recommendation is to avoid it. These are some of the echo statements and just overall view about what drugs can be used and which are contraindicated and or should be avoided. This is an update recently by Rupert Leong's group, again, showing reassuring data that when it comes to lactation, most drugs can be used with the exception of methotrexate, cyclosporin, and it is felt, although there's little data, that tofacitinib should probably be avoided. What about going on to, we often focus on the baby, but what about the mother? And I think that's something else that we should really be thinking about more as well. And like data on, postmenopausal women and women in general, as Bharti said, there is actually surprisingly little data. We do know, however, that patients with IBD are likely to experience postpartum flares. And why do you suppose that might be? Well, I'll talk about that a little bit, but these are some of the issues that we might want to consider. So, postpartum wound infections was something that was brought about some time, especially with the use of immunosuppressive therapies and anti-TNFs. But again, reassuringly, data from the piano group actually found that it's actually safe and that anti-TNFs did not increase the risk of post-operative infections. So, and actually biologics can be resumed 24 hours after vaginal delivery and 48 hours after C-sections. What about in terms of postpartum flares? Well, the thing is that flares in the postpartum period is pretty common. And again, it's the same sort of thing. I think if you come back to my patient, I'm quite sure that she probably stopped all her medication because of her fear, and therapy de-escalation or maybe stopping pregnancy altogether is probably an important risk factor for postpartum flares. And in fact, in this particular study, almost a third of patients had a postpartum flare. So again, just to show you again what had happened to my patient, where she presumably didn't take any of her medications and again presented a flare 4 months after her baby was born. More worryingly as well is that there's also a relatively high risk of postpartum flare hospitalizations, which of course have a higher morbidity and higher health utilization costs. So you can see here that the risk of postpartum flare can actually persist even up to 6 months. These are all the percentages of flares throughout the postpartum month. Now, Rupa is doing a big collaboration with us in terms of mental health, and I thought this was something you wanted to bring up as well. Postpartum depression is common in women without IBD, and I think the spotlight now is also coming towards mental illness in terms of IBD in the IBD women in the postpartum period as well. And in this particular study, they actually showed that women with IBD are at elevated risk of perinatal mental illness, and that was in the form of mood and anxiety disorders and substance abuse disorders. And it's really seen in the postpartum period, and it's more associated with Crohn's disease. And these were some of the correlates of postpartum mental illness that was found. So as you can see here, from this study by Vigot et al. That patients with IBD compared to the non-IBD group as a reference range had a slightly increased risk of mood and anxiety disorders than alcohol and substance disorders, as I said in the previous slide. So in summary, just wanted to say that most vaccinations are safe for the newborn except for live vaccines. Although, as I said before, some data, shows that perhaps the risk is not as high as we think it is. IBD patients are less likely to breastfeed their babies or discontinue their therapy, despite the fact that most medications are safe. And I think we should consider certain things like postpartum complications, such as IBD flares and mental illness as well. And with that, I thank you, and I leave you with a picture of one of my favorite mothers, Dr. Rupa Banerjee. Thank you.
Thank you, Ida. That was a wonderful picture. Post-COVID, it actually seems such a long time ago, but I'm sure the next year will be better. We've had a lot of questions coming in, but I think if Dr. Ramesh, so I think we'll first go beyond scientific to the social issues and then come back to the questions to give some more time for more questions to come in. I can see 6, 7, 8 questions already, but over to you, Dr. Ramesh.
Thank you very much, Rupa. I think we had 3 excellent talks, and I congratulate the 3 speakers for the very, very strong messages. I think the social issues that I would like to bring up, the first one, of course, starts at our backyard, in your backyard. I think Ida did refer to that. Even though we have enough evidence to say that most of the drugs are safe during pregnancy, our obs and gynae friends just refuse to accept that. And that makes things quite worse. Now, I would actually be interested, Rupa, in knowing how many obs and gynae people are there in the audience today. There's no way to but my guess is that most of the audience is probably physicians or gastroenterologists, which means that a topic or a theme with an outreach potential to obs and gynae, we are not able to do. So I think my question to you, Bharti, in your area, in the States, how is it that you are convincing our gynecology friends that, look, most of these molecules are safe, there's absolutely no problem. It's particularly true for azathioprine. I think that is what the gynecologists are extremely scared. How is it that you overcome this problem?
That's a phenomenal question. It's something we struggle with in the States as well. In the United States, there's a specific subfield of obstetrics called maternal fetal medicine. They're high-risk obstetricians. So they take care of the sickest of the sickest of the sick people. And so what I've done at every institution that I've been at is first find an obstetrician, a high-risk obstetrician, and become friends with them. And what I try to do is I reverse convince my patients to go to the high-risk obstetrics group. Typically at the big centers, the high-risk obstetrics groups, I mean, even not just one person, but a couple of people are quite comfortable with all of the medications we use. And the high-risk obstetricians will always, and time again, even when I'm nervous starting steroids in the first trimester, they'll say, take care of mom, we'll take care of baby. Do what you need to do for the mother. Keep the mother healthy. That's your job. We'll keep the baby healthy. And so you're absolutely right, finding that type of obstetrician is difficult. So I feel that it's actually easier to have my patients see the obstetrician that I work with closely. Obviously, like in all of your practices, that's not always possible. We have patients traveling, many hours, and obstetrics is not something you can do locally, or you can have your obstetrician 5-6 hours away. So in those situations, I mean, I try to do everything that Ida described, but life is not perfect. We try to write the letter and we try to put in the literature and say, we really recommend this. We had this long conversation. But something that both Erit and Ida said is just having these conversations early with a woman, even well before she becomes pregnant. So I talk about it with my young patients, even with their mothers in the room. I say, I know you're probably not planning to get pregnant now, but 10 years from now, when you want to be pregnant, or, you should know that a lot of these medications are safe. We should talk about it ahead of time. And then I think starting that conversation early with women gets them comfortable too. So when their obstetrician tells them to stop their medication, they can say, let me check with my doctor.
Yeah, we'll come to that counseling bit a bit later. Dr. Jayanti comes from a place where there are very well-read obstetricians, gynecologists. Dr. Jayanti, do you face the same problem? I honestly do. And that is why I'm raising this problem. We need to spend a little bit of time on this. How is it that we actually convince our gynecology friends that, look, it's not as bad as, because the first impulse is, moment a patient with IBD becomes pregnant, the gynecologist will say, obstetrician will say, stop all this. You face the same problem, Dr. Jayanti? You can unmute yourself. You could unmute yourself, please.
Most of the patients that I've come across, just a couple of you maybe, were patients with ulcerative colitis. So Crohn's has never been a problem, and pregnancy has never been an issue. The problem that I have faced is that most of these women, they do not disclose that they have an IBD before marriage. And lo and behold, when they get married, within 6 months, they say that it was soon after marriage that they started having this problem. So I've had at least few occasions, at least 3 or 4 occasions, and this is common, at least in India, that the girl has to get married when she's to leave the home. So that is what is expected of the family. And they don't disclose. So there was one patient who actually had very severe ulcerative colitis when she landed in UK, and she had a subtotal colectomy, and then she had a colostomy. It was almost, it went to the extent of a separation, and then we had to do some counseling between the husband and the wife, and somehow a year or 2 later she managed and she conceived. So these are some of the issues. And one other thing was, they would tell, the mother or the mother would say, please do not disclose this to the boy, and say that all this has happened after the marriage. And as far as the medication is concerned, most of them are on mesalamine because they're on ulcerative colitis. So steroids does not come into way there. And azathioprine also have not really faced much of an issue in many of the patients. Most of them are on mesalamine. And what I do advise, I had recently a doctor from Trivandrum whose wife, when she had this active flare, then I told, just plan for a pregnancy when in remission. And she went through, and they have had a nice baby. I think that remission bit is something that's very important when we are talking to the...
Yes, I think that message was very loud and clear
during remission phase.
During remission reduces risk of adverse outcomes. I think that was very clear. Rupa, you got a huge series. Now, let me tell you, just for the benefit of the audience, I know it's not for the benefit of the panelists, IBD in women is different from men. What are the important areas where there is a difference between IBD and men?
Above the age of 50. Let's take above the age of 50. Yeah. Menopause on this side and men on that side.
If you thought you'll sit back and relax and listen to this panel, this is a tickle for you.
Yeah, I think this is a very good question, and first and foremost, I would like to agree with what Dr. Jayanti said. There is this, there's a lot of background noise coming. Can you do something about it?
Yeah, it's correct. Yeah.
So I think I completely agree with Dr. Jayanti. This is such a delicate question. We talk of drug adherence, and I particularly see women face this, that they have not even told their partners or husbands about their illness. Their drug intake is therefore hidden, and this is not one. It will be surprising to many. So the drug adherence becomes an issue, and when there is a flare-up, they come and meet you as if they are meeting you for the first time, and it's difficult. So between IBD in men and women, I think pregnancy, conception, breastfeeding, the entire gamut that we are covering today, Dr. Ramesh, is so close to every woman. I think the slide that Ida showed, I mean, and it's so important. Even a young lady who is diagnosed with ulcerative colitis, the first question is, can I become pregnant? Will my child have IBD? And are the drugs safe? So we are talking of, and you asked about the obstetrician friends who somehow feel that, okay, we should not give drugs, but sometimes it's the mother as well. I mean, if I'm doing well, I don't want to take even that little risk. So whenever I talk about it, I feel like saying that this decision, in fact, even as IBD specialists, we cannot give 100% on any drug. And we cannot guarantee a safe pregnancy to any mother. So it has to be a combined discussion and then finally a decision taken. And I always use the term that, literature says that it is safe. So if you want to continue, you can. If you are stopping, there are increased risks, but we will handle those risks. But we cannot say that, you must take the drug, otherwise there will be wrong. And I think I'll ask the others for their opinion.
Yeah, I would like Dr. Irit's opinion. Now, is the situation similar in Israel? Because do you find partners or potential partners? Here, of course, we have the families of potential partners coming and asking us about a patient. The question is, the dilemma is that how much should we reveal? How much should we conceal? That's it's a huge problem. What about Israel, our situation there? Do you get such situations? Do you face such situations? Social life.
Yeah, definitely. In our country also, I think women, it's very natural and understandable that women are a little bit scared and they have concerns regarding the use of medication during pregnancy. So I need to have this discussion with the patient and with her husband and with the mother-in-law, and I have to convince the whole family that about the risks of discontinuing and about continuing the drugs. I fully agree with what you said, Rupa, that I tried to give a firm statement in my talk because I do think that things need to be said in a like a obvious way, but we don't know everything about exposure, long-term exposure, the immune system of the child to be. We don't have the whole information, but still, when you see premature deliveries of babies at week 28 or 30, then it convinces you that the continuation of therapy is very important. In our country, we have shared clinics that we see the patient together, the maternal fetal expert and the gastroenterologist.
Once again, there is some
background noise.
It's stopped.
Yeah, I think
Yeah, this is better now.
Okay. Yes, please carry on. Have you completed?
I think that the concept of shared clinics, in which we're fortunate to have, I see my patients with a gynecologist. We sit in the room together and we see the patients that are referred to us. So this helps us give a firm one voice to the patient.
So two important lessons. One is, of course, it all depends, especially in ulcerative colitis, what time or what period of the disease the conception occurs. If it occurs during remission, the chances of an uneventful pregnancy is quite high. The second, of course, important message is that almost all drugs, other than methotrexate and quote-unquote Postpartum, are safe in pregnancy. Now, the concept about this combined counseling, now Rupa and Bharti, maybe I could have your opinions. Does it happen? Now, looking at all the facts that have been put forward, I think it's the most vital thing is probably to have a counseling session for all the ladies or females with inflammatory bowel disease. Do we have a group counseling sessions or individual counseling sessions which happen? because that is going to sort out a lot of problems. I'm afraid in the place where I'm practicing, I don't think we have formal counseling sessions like that. Does it happen in Hyderabad, and does it happen in the States? Rupa, first you and then Bharat.
Yeah, so I think you knew the weak spot. Yes, we for pre-surgery, the formal counseling is very well done because we involve everybody, and there's a board which is held before a colectomy. But regarding pregnancy counseling, it's usually not there. Sometimes it is a phone call for a referral gynecologist who has referred, or we are sending a patient, so we tell the basics. Sometimes what I do is I call the obstetrician in front of the patient. So that kind of, in your practice, that saves you some time, and you, the patient hears what is being discussed with the gynecologist. So ideal case is yes, but what we do is what I am telling you, depending on the situation. So I at Hyderabad, yes, we need to improve on that aspect from telephone to real life.
What about you, Bharat?
Absolutely. I think it's very important to do. Unfortunately, the way that American medicine is set up, it's very difficult to do the combined counseling where we're sitting physically in the room with the obstetrician or gynecologist or even surgeon, quite frankly. But what we do is we make sure that we write good notes, share with each other, like Dr. Banerjee said, get on the phone with each other, oftentimes after, though, in the evenings. And there are some centers in the U.S. where they have basically an IBD OB clinic, and so what they do in these centers is that any woman, when she's pregnant, just gets sent to this clinic. So the main IBD doctor just stops taking care of them, and then through pregnancy and the postpartum period, they're in this clinic. Then they go back to their IBD doctor. That's a good model. I personally don't like letting go of my patients for that one time. So I do have a formal visit, though, that I call the preconception counseling visit, and this is hopefully before they're pregnant, and we talk, and anyone who wants to call in, join, whatnot, we talk about all of these things. I direct my patients to a website called the IBD Parenthood Project that was sponsored by the American Gastroenterological Association, but with inputs from actually some of the international IBD groups as well. It's patient-facing material for women who are considering pregnancy or pregnant or have had children, just to kind of discuss and address all of the issues around childbearing as a young person. And so actually some of my men benefit from this as well.
Okay. Dr. Jayanti, any questions from your side? I think it's now time to get scientific. Talk about social issues.
I'll quickly go through the questions by the time, and then we can end with a little bit more of the non-scientific. So questions, I think I'll start with Ida. Ida, the first question that has come for you is, what would you recommend is the minimum duration of breastfeeding for IBD women? In case they are in a flare, or just, can they stop the breastfeeding, forget about the fear, and then start off? So the question is minimum duration of breastfeeding. How long should the mother breastfeed at a minimum? I mean, just so that the child gets enough antibodies. I suppose that is what is meant.
Well, I guess the minimum duration of breastfeeding would be the WHO recommendation, right? Which would be 6 months. I can ask Dr. Kohar and Dr. Avnibiran whether, Irid and Bharati, whether they feel any differently, but I would say exactly the same as what WHO recommends. And I think that's the whole point. I would like to, that in fact they should be exactly the same as
So there is
non-IBD women should, but they often.
Yes, so there is a second question for you. Biologics, when to start? If it has been stopped in the 3rd trimester, when to start biologics again post-delivery?
So I presented that already. You can start it immediately, like within 24 to 48 hours. I don't know who would come in if it's infliximab. I suppose if they're in hospital, that would be okay. But if they're not, then they may not feel like they want to come in to take their biologic therapy. But as soon as possible, I guess, would be my take on it. And I think really, I really found a shift in my own practice. Last time I did also try to stop in the trimester, but I have really been very reassured because I've actually, those patients who are at high risk of flares, I usually just carry on and I just do it exactly as per normal. Yeah.
So even if breastfeeding it is to be started at the earliest. There is another small question for
Rupa,
you.
could I just barge in a little bit, because we are on the topic of biologicals and biologics. I would like to ask Dr. Irit. You had actually shown very interesting statistics or studies which compared infliximab and adalimumab. And one look at those figures gives me the message that during pregnancy, adalimumab probably is a better biologic to use than infliximab. Am I right or wrong?
So the study that I've shown was regarding 10 women that received adalimumab during pregnancy and 11 that got infliximab. But there are additional data about cord blood levels that definitely infliximab has the highest ratio of infant to maternal cord blood. Yet, I would not say, I would definitely not say that patients that are on adalimumab should be switched to infliximab, or even it's not my consideration when I see young females and I choose infliximab or adalimumab. It's not much of a factor for me to decide. But yes, the levels of infliximab are higher as compared to adalimumab. Still, the decision regarding which biologic should be selected, I think, should be according to other factors and not only this factor. There is also, if you want to complicate it a little bit more, there's another anti-TNF that is called certolizumab pegol, but it's not very common in most countries. But this type of biologic is not does not cross the placenta at all, and is only in the maternal blood. So to summarize my answer, I would say that the decision about the biologic should be according to the IBD status and not from this factor.
Wonderful, wonderful. Dr. Jayanti, anything from your side before I go on to the next question from Rupa?
I think Rupa has a few more questions. We can finish the chat box questions, I think.
Rupa, finish up the chat box questions.
Yeah, so there is this question which says, again to Ida, human papilloma virus vaccination. When would you suggest it be given? And what is the schedule is the question. What vaccination schedule for HPV vaccination? This is a good question. Yeah.
That's a good question. I guess
every woman
can everyone have it? Yeah.
Currently recommended. It is currently recommended for teenagers. In most, I think, in many countries, it is recommended as part of the national immunization at the age of 14 or so, both for boys and for girls. It's not a live vaccine, so it can be administered for patients who are receiving biologics or immunosuppression also. It's something that is not, it doesn't have to be during pregnancy, of course. It's in women or in patients immunization program. This is one of the immunizations that is recommended.
Yeah, that's what I was
So
Yeah, that's what I was going to say, because I can't imagine. Hear me? Yeah.
Yeah, now
Voice is breaking, so I think there's some problem with the network bandwidth. So
Yeah, I think my
maybe if you could just
internet's,
put off your video for a short while.
I think so. The
Yeah.
summary would be that before giving biologics, we should check for HPV vaccination status.
Yeah, no, absolutely. I was going to say that HPV vaccination should be in everyone, and more so in IBD women. And I think we know this, that IBD women are more likely to have abnormal pap smears. I think this is old data. So it's a very important vaccine, I think, to give. I can't imagine that people would give it during pregnancy or postpartum, or early in the postpartum period. Sorry, there's
Rupa, are we practicing this in our country?
background.
I don't think. Rupa?
Background noise. Yeah. So I think, so I can't imagine that would be the priority, but I think it's interesting. I didn't present this data, but there was also a study to also show that, things like this, vaccination, osteoporosis screening is also reduced during the postpartum period in IBD women and yes. The answer to that very simply is that I think HPV vaccination should be done for all women of us. I think the age is 20 to 65, if I'm not mistaken. IBD patients even more so, perhaps.
And just in response to the schedule question, that depends on which vaccine. There's actually a couple of different HPV vaccines. So there's one that's a 2-dose vaccine. There's one that's a 3-dose vaccine. So you should check with, which one you have available.
Are we practicing this in our country?
I can answer for Hyderabad. We were actually not very particular on the HPV vaccine status. We always thought that teenagers would have had it. But recently, we've just started a vaccination checklist before giving biologics, and HPV vaccination status is included in it. And I think that's a very good way for the audience. Just keep we've just made a sticker. It's pasted on the IBD booklet, and they're just asked to complete that whenever they are diagnosed with IBD, so that even when in future you're planning biologics or other therapies, the vaccination status is kind of complete. So yes, in Hyderabad, we are just doing that. So can I go ahead? I think there are some simple questions which have come. Dr. Bharti, there's a question for you that hormone replacement therapy in elderly patients with IBD, since it's a thrombotic condition, should we avoid hormone replacement therapy?
That's a great question. In general, hormone replacement therapy has fallen significantly out of favor for women to treat menopause symptoms, and at least in the United States is used only in extremely dire circumstances. It is obviously prothrombotic. Active inflammation is also a prothrombotic condition. So that's another reason not to do it in women with IBD. But in general, there was actually a trial published in the early 2000s in the New England Journal of Medicine that really highlighted all the risks of hormone replacement therapy. There's a higher risk for cardiovascular disease and osteoporosis with hormone replacement therapy in older women. So in general, hormone replacement therapy for all women should not be done just routinely. For the severe symptoms and cases, yes, I do have a couple of patients who needed short courses. I'll ask, to keep it as minimal as possible, and, hope that they don't have a thrombotic event. If they're actively flaring and on HRT, then we talk about sort of other thrombotic prophylactic agents. But it's very difficult to, just kind of automatically put patients on aspirin or other kind of antithrombotic agents without any evidence guiding that. So I don't start any other medication in addition. I just, ask them to be as active as possible and use, calf squeezing tights and things like that.
There was data with Dr. Koha that hormone replacement therapy might reduce flares. Is that right? I thought there was one study. Was it by
Sorry, I missed that word. That might be.
that may be protective against flares in IBD patients, HRT. What's your opinion on that? I think that's
It was a very small study. It was, retrospective, and it was in, 60 some odd women. And so, maybe it could be protective, but I think big picture, our IBD patients have the same threat to lives as, most patients in modern societies, which is cardiovascular disease. And hormone replacement therapy has been proven in a randomized control trial to really be a significant risk for cardiovascular mortality. So I always try to place things, in that context. So there are other more modern ways of administering hormone replacement therapy as well. I'm not aware of all the details, but in general, I don't recommend it routinely.
Rupa, I have a question. All along we've been discussing on ulcerative colitis, I think, as the kind of listing of IBD. What about the experience with Crohn's disease and pregnancy, especially the fistulizing Crohn's? I've really not come across very many women with pregnancy and Crohn's disease. So probably you can share some of your experience.
So from
Pregnancy and Crohn's, yeah.
So I think from the Indian perspective, we have seen many patients of Crohn's disease getting pregnant. The issue remains the same, that if the disease is quiet, then we don't see worse outcomes. Personally, we feel that low birth weight becomes an issue because sometimes Crohn's disease patients are more malnourished because of chronic stricturing disease and malabsorption perhaps. So they are more malnourished. So they need specific intervention to see that the general nutrition is high. And anyway, we are keeping them on folic acid and things. The issue becomes if there is active perianal disease, I think we suggest that they should go for cesarean section. And I think in this aspect, even obstetricians agree. So it's a planned cesarean. But in general, even in Crohn's disease, low birth weight and other things because of malnutrition, otherwise outcome wise, we don't see much difference. So maybe Irit can give the what happens there.
I fully agree with all the things that you said. I think that it was very important that you mentioned the nutrition aspect. There is data that associates gestational weight gain to pregnancy outcomes, or that shows that insufficient gestational weight gain is associated with higher adverse outcomes of pregnancy, such as small for gestational age. So nutritional support is very important. If a patient has active perianal disease, we also recommend cesarean delivery, and it is also supported by the guidelines. And if a patient has a perianal abscess during pregnancy, then we need to treat it surgically or antibiotics. Or the main issue is to do all the things that are needed for the mother's care during pregnancy as well. But hopefully, preconception assessment also can help us avoid problems during pregnancy.
I just want to ask a little provocative question, and I think I'll ask Dr. G.N. Ramesh also for his opinion. We have mothers who have had one healthy child. The disease is quiet, or even if the disease is not quiet, they want to plan the second pregnancy. Now, we know that whatever we say, there are the risks of, pregnancy, flare-up, post-pregnancy, the increased risks. Should we discourage going for the second or the third pregnancy? Because I've had patients who come and say, I have 2 healthy kids at home, but we want a daughter or we want a son, and should I plan? So I think I'll just take opinion across regions. Dr. Jayanti, what would you do? And then Ida and then Bharti. Just quick thing. I mean,
I personally feel that if they went through a pregnancy that was smooth, I'm sure they would proceed to the second or the third. But if they have some problem, management, and there was some flare, and then there was a risk of delivery and all that, then I think automatically they would go for just one child. That's what I would.
Ida.
I think this is very sensitive. We don't have a policy of encouraging one child policy like in India, and people like to have quite a few children in Malaysia. So I guess I would not actively discourage them, but definitely their disease has to be well controlled. And it's anecdotally, I had a really terrible case of someone with a rectovaginal fistula, a young Malay teacher, who, I really pulled her back from the brink of death. She was 28 kilograms. And as soon as she got better on infliximab, she got pregnant. And I was really thinking, God, I should have, and she had a terrible course, finally deliver the baby and everything. And after all that, and I said, look, you mustn't get pregnant again. I mentioned all this, but unfortunately, the husband thought otherwise, and she got pregnant again.
So
I think that's the other thing.
Tempted sometimes to tell the patient that you have a healthy, you have a family, you have 2 kids, and you're doing well. Why disturb the balance? But Dr. Ramesh, I just wanted to ask you, we are all, women seeing patients, and what would you tell your patient? I mean, would it be like a little more stronger? Well,
I think the 2 variables that actually would determine the advice would be how the patient went through the first pregnancy, and number 2, of course, the disease activity at that time. These are the 2 things that I would look at. Now, if the patient has undergone a pregnancy which is uneventful, I don't think I should discourage a second pregnancy. Third pregnancy, yes, I may say, yes, it's good. It's a bit too much, but 1 and 2 is okay. Second is, I make sure that I talk to her and her husband, a partner, together. Very often what happens is the patient comes alone or with her mother or someone. The husband is missing from the entire scene. So it becomes very difficult. It's an incomplete counseling, this one. So these are the 2 things that I would actually really bother about.
Bharti, anything to add from your side?
Yeah, so, the one thing I do tell patients, again, the United States has a very different cultural mores regarding, pregnancy and childbearing, but the obstetric literature with immunologic conditions actually suggests that every pregnancy is different. So I have some women that say, I can never get under control, and then I'm pregnant and I'm fine. Everything is great. And so there's this immunologic rule of thirds in pregnancy. A third of women have their immunologic condition, whether it's psoriasis or lupus or IBD, that gets better, a third get worse, a third stay the same. So it's a total random chance. But I say, maybe you're that person that got better in the 4 pregnancies previously. The 5th pregnancy can be the pregnancy where you have a terrible flare and we're doing crash surgery in your 2nd trimester. So, you have to decide what risks you want to take. And the best way of going into pregnancy is being in remission, even if pregnancy is what got you in remission the other 4 times. And I say this because these are patients that I've actually met. So as long, just like Dr. Hilmi said, as long as they're in remission, I don't discourage it, but I really try to push for that remission.
As equally important is the spacing between pregnancies as well. Do you think that that's an important consideration?
I'm just taking this question because I somehow, and this happens sometimes, I feel that if they have 2 kids and they're stable, I tend to feel that it's better to even guide them that, but society and societal things there's a lot of delicate in-between things that, so as doctors, sometimes we can subtly influence, and I think our soft skills are put to use for that.
Soft skills and communication skills.
Yes. So I
Yeah.
just have a
something to
lot of questions coming in as they're writing it for me. Most of the questions actually have been covered in the talks, but there is one question for Irit which says that should IBD patients planning contraception be offered only intrauterine devices as contraceptive or to avoid oral contraceptives?
So we shouldn't avoid oral contraceptives. I did in my talk showed some favor towards progestin only contraception, but we can use progestin only pills and as well and patches and your intrauterine devices. So patients with IBD can definitely use the pill. The discussion should be between them and the gynecologist, and they should be introduced to all the pros and cons of each option, and they definitely can use the pill if it's more convenient to them. There is a slight favor towards a progestin-only pill as compared to combine estrogen and the progestin pill.
Would you recommend that, or would you be still okay if they did combine pill?
I tend to recommend the progestin-only option, but if the patient tells me that she tried it and she had in-between bleedings that bothered her, so I would say, and if she's not a very high risk for venous thromboembolism, as I mentioned, and the common risks, then I would be okay with combined hormonal therapy, and I would say choose a pill that has a lower level of estrogen in it. So the more advanced generation of pills.
Just switching over to the bone density and then osteoporosis and osteomalacia. My question to you, Bharti, is that bone mineral density, does IBD as a disease hasten the process of osteoporosis? If so, prophylaxis with vitamin D and calcium, as is often done, is it evidence-backed?
That's a great question. So there's actually reasonable evidence supporting that IBD on its own, so not in women, not in people on steroids, not with other risk factors, but just inflammation, systemic inflammation on its own is a reasonable risk factor for osteopenia and osteoporosis. Patients with IBD are typically young, as you all know, and they already have a pill burden. So I don't like to prophylactically just add on calcium and vitamin D. Any patient on steroids, even if they're the enteral only budesonide, I say take a over-the-counter calcium vitamin D supplement for the course of steroids and for 2 to 3 months after. And then, even as steroid sparing as we try to be, most IBD patients at some point in their life have had 3 months of steroids. And so I will get a baseline bone density test, even on my young men, once bone formation is solidified. So it's actually in the late 20s. So starting in the 30s, I start screening for thinner bones or low bone density. And if there's even, any inclination of lower bone density, I'll say just get on a calcium vitamin D. It's easy enough. And then we'll follow it up. Once it's real true osteopenia or severe osteoporosis, I send them to an endocrinologist. There's very good medications these days to treat osteoporosis, but it's something to think about in all patients with IBD, but especially older women, because that's a baseline. Being, older, being female, in addition addition to having a systemic inflammatory condition, are all significant risk factors for low bone density. So a lot of general primary care doctors actually don't know this. This is very much obviously in the primary care realm, not in gastroenterology. I wasn't necessarily specifically trained for this, but because primary care doctors may not know that a systemic inflammatory process is a risk factor, I'm the one to bring it up. And oftentimes I'll say, go get the bone density test with your local doctor, but just make sure that someone's thinking about your bones.
Moving on to another question. I think, Rupa, if you have time, 2 minutes, 3 minutes.
I think we just have time enough for one question.
One question. Okay. This is to Dr. Edith. You mentioned about the risk of thromboembolism during pregnancy, the thromboembolic component. How exactly do we objectively assess the risk of thromboembolism? And if at all it is high, of course, now we do say that prophylactic anticoagulants may be the way to go. Is it equally true for ulcerative colitis and Crohn's disease?
I think that both diseases are associated with increased risk. The risk is high in patients with active disease and in hospitalized patients. So these are the, I think, most important risk factors, and my colleagues maybe can comment also, but hospitalization and active disease, and obviously if a patient is referred for surgery. In patients that are with active IBD and definitely for colitis as well, who are hospitalized, we give them low molecular weight heparin prophylaxis. And during the hospitalization, during the cesarean delivery, and afterwards. And there is even a recommendation to continue this at postpartum. To tell you that I do it in all my patients at the postpartum period, I wouldn't say that I do, but there's even a recommendation for that.
Any other?
I was going to bring that up, but I thought it was a little bit because I was short of time about the VTE risk in the postpartum period. I think that is the problem, isn't it? I've often asked about this, even in those with flares, they should all be on, heparin, low molecular weight heparin prophylaxis. But the recommendation is to actually carry on. I think this was Rupa, the very controversial talk at the IBD Masterclass. That some people recommend continuing it 3 to 6 months after. Yes. And I was thinking, my goodness, are you going to inject someone, with low molecular weight heparin all those months? And I wondered how many of us actually do it, because I certainly don't. I usually stop after the hospitalization.
Yeah, I think there are many missteps. And I think at the APAG, the Asia Pacific group, we have actually done a whole series on the missteps that even as IBD specialists we make, and I think thromboembolism and treatment for that is one of them, definitely. But I think, Dr. Ramesh, your concluding remarks.
I think we had a very useful discussion, 3 great talks and a very useful discussion where we've actually brought up a lot of points, even though the theme for the discussion was beyond being scientific. But I think 3 or 4 important messages that we need to sort of drive home is, one is, of course, be it ulcerative colitis or Crohn's disease, the timing of conception is important. It has to be at the time of remission, when the patient is in remission. And that is one of the most important factors that is linked to risk of adverse outcomes. The second important point is, other than methotrexate and tofacitinib, and of course thalidomide to a large extent is not used nowadays. All the other drugs are safe, including a short course of steroids for the control of flares. Third is, I think we should pay more attention to counseling, and this counseling should start very, very early during the patient-physician interaction, and the counseling preferably should be a group counseling, which should include a psychologist and maybe a gynecologist as well. I was very interested in that website on IBD Parenthood Project, which Bharti did mention. I think if you can get some some idea out of that, we can probably try and duplicate it here also for our patients. But I think these are the important messages that I would like to highlight while bringing this panel discussion to a close. Thank you very much. If there's anything, Dr. Jayanti, you would like to say before Rupa takes over for the final.
Nothing much. Nothing much, Jay. You've added on most of the points and the key messages have been mentioned.
Thank you very much, and thank you very much, Dr. Bharati, Dr. Irit, Dr. Ida, and of course, it's over to you, Rupa, for telling us what we have next.
Yes. So thank you, everybody. So our next month is very special, and it's very special because we are going to celebrate Professor Simon Travis's illustrious career in medicine and inflammatory bowel disease. He is the mentor and pillar for the IBD Emerging Nations Consortium, and we salute him every day. But this month will be special on the work he has done and inflammatory bowel disease, what the future, how he foresees it, and of course Simon will be there for the same. So I also, no meeting ends well unless we mention our strong academic partners. I'm particularly grateful to Janssen & Janssen, Dr. Reddy Labs, Micro Labs, as well as Takeda for providing us academic support to have this masterclass, as well as the www.ibdenc.org, our web platform. Thank you. Good night, everybody. And it has been a real pleasure. Thank you all, the lovely speakers. International Women's Day, look at the team. And Dr. Ramesh as the center point, coordinating the entire show. Thank you. Thank you so much.
Great. I think that is great.
Bye-bye.
Yeah.
Thank you.
Bye.
Bye-bye. Good night.